Hi, good afternoon, friends. It's lovely to see everyone and be here in person and not behind a screen. Although some of you are quite far away, but it's perhaps closer than you would be if you were by Zoom, so we'll let it slide. Good afternoon, and thanks for joining our didactic on what's in a registry. This is focused on trying to understanding, designing, and implementing clinical registries with a focus on resource-limited settings, but we think the principles will apply broadly. This is a big topic, of course, and I think we're just sort of scratching the surface today, try and sensitize you all a little bit about some of perhaps the learning lessons and some of the key principles in designing and building your registries. I'd like to start with a round of introductions, so perhaps from your right to my left.
My name's Julia Dixon. I'm at the University of Colorado, and I focus primarily on sort of education and emergency system development and have been working on some registry projects in South Africa and sort of informally with some countries that have been implementing the WHO registry.
I'm Catherine Staten. I'm associate professor at Duke and vice chief of faculty development. We lead the Gemini Center with colleagues where we focus on innovation and implementation science using a framework of registries to guide our direction. I have experience with starting a short-term registry in Mozambique, and then since then I've had almost a decade-long registry in Tanzania that has adapted through the years. So we'll talk about that.
And I'm Nee-Kofi, Mould-Millman. I'm an associate professor of emergency medicine and global health, also at the University of Colorado. I'm a pre-hospital and early resuscitation trauma researcher with also a background in implementation and dissemination science. In terms of conflicts, it's important to note that the three of us are actually investigators on research on grants that fund the registries we're going to, at least two of the registries we're going to talk about. And Dr. Dixon is also a consultant, was a consultant at the WHO. And these registries were, at least the one in Tanzania and South Africa, are funded by several federal grants from the NIH and the DoD. And we'll talk about those in the context of this presentation. So again, this is a broad topic. Some of the things we hope to achieve over the next 45 to 50 minutes are to define the key components of a registry, to talk about the value and the uses of clinical registries, to discuss some strategies to implement and sustain these registries in low-resource settings. We all know that sustainability is often a huge challenge. And then lastly, we'll try and review and critique a few materials, not a ton, but we'll lightly skim on this. And at the end of this, we'd invite you all to ask us any and all questions, with the caveat being registries are diverse and we may not have all the expertise represented. We probably won't have all the expertise represented up here, but we'll try our best. So why learn about registries? So in a nutshell, a registry can be thought of as a really high-quality repository or database that is created and entered in a very systematic and a very rigorous and thoughtful way. And it's primarily designed to capture either specific diseases, information about specific diseases, or about specific populations. And the end goal being trying to improve clinical care and perhaps some systems level improvements along the way. So in the US, on high income, so I'll back up a step. So a recent systematic analysis showed that the majority of registries, of clinical registries in the world, really exist in high income settings. In the US specifically, I think you all may know of registries around cardiac arrest, around trauma, around stroke care, to name a few. And you also know that some of these registries have been really critical for advancing care, both at the facility level and at the regional level. So take stroke registries, for example, actually have been critical to informing interventions like CT scans and ambulances, as cost ineffective as they may be, or pre-hospital notification of strokes and patients going straight from ambulance to CT scan and so forth. The data to drive those processes really have come from, by far and large, from registries. Same can be told for trauma care and so on. So in general, registries provide us with insights into local burden of disease. They're a critical source of information for both injury and disease prevention. They do provide a rigorous framework for quality improvement. And to be honest, in high-income settings, I'll speak for the US, quality improvement is perhaps the primary reason why registries exist, and research is typically conducted secondarily. Registries also inform resource allocation, like I explained before. They provide robust data to help support policy change, both again at a facility or clinical unit level, but also at a regional level. And I think one of the most important points we want to leave with you here today is that a registry is actually a tool, a versatile tool that can be used to satisfy a diversity of purposes: research, clinical improvement, identifying gaps and opportunities for education, and so on. So with that background, would like to sort of set us up for the next 45 minutes. So what we'll do is Dr. Dixon will go first, and she'll talk about the WHO's International Registry in Trauma and Emergency Care to give you an example as a case study of sort of a global registry that exists already, and to talk about some potential uses. And then I'll go next and talk about a trauma-focused multi-center registry in South Africa. And then Dr. Staten will go last, and she'll tell you about a TBI registry that subsequently evolved, and the evolution of a registry into registries in Tanzania. So that's our lineup. And at the end, hopefully we'll have about 5-10 minutes where we can do some good question and answer.
All right, so we are going to use IRTEC, or the WHO's International Registry for Trauma and Emergency Care, to talk a little bit about your data collection, and then some data analytics. So kind of starting at sort of maybe some of the first things that you're going to think about when you're building a registry. Like Nee-Kofi mentioned, this registry was primarily built to support quality improvement of emergency care and not necessarily as a research platform. And some of its unique features is that it has integrated analytics and some visualization dashboards, as well as some standard reports. And I'll show you some examples of those. So a lot of times when you think about building a registry, related to data, the first question is, what data are you actually going to collect? And the answer is not all of it. As academics, that's maybe where we would think that we want to go, but it turns out collecting all the data you can actually creates a lot more challenges on the back end and really limits sometimes what you're able to do with that data. Thankfully, there are actually a lot of things that can help us guide what data we're going to use. The first is the FAIR principles, which is the idea that the data basically can interconnect with other data sets. So FAIR stands for findable, accessible, interoperable, and reusable. And basically what it means is that you have very clear definitions of each of your data variables, and that you can communicate with other data sets. There's a lot online actually related to these principles, and so I'll let you guys kind of look at that a little bit more, and I think you're going to talk about it as well. So one way that we can kind of follow FAIR principles is to use an existing data set. And so the WHO has a minimum data set for injury. This is available online through their website. And there are many other sort of standardized data sets that are available. There's sort of the US National Trauma data set. There's a military trauma data set. And so you don't have to create your data variable set from scratch. You can actually build it off of existing minimum data sets. And then you can build up if you have additional research questions that you're trying to answer, but you usually don't take things away. This data set, just so you guys know, was built through a consensus process. And it's really, really important to think about what question you're asking when you're building this data set. So this can be driven by either the research question that you have, maybe because that's who's funding your registry, or your kind of primary stakeholders who have a specific subset of data that they're interested in. So as Dr. Staten's going to talk about, her registry started more as a TBI registry and has expanded because it made more sense to kind of focus in first on one topic and then get broader as kind of time went on. So once you've picked your kind of variables that you're going to collect, you then have to think about how are you actually going to collect them. The ERTEC uses the DHIS2 open source platform, which is really just a fancy way, I feel like, of saying it's a secure platform. And it's available both on mobile platforms as well as offline. I think the other most common registry platform that's used is REDCap. A lot of us have access to that through our universities. And there are registry sort of databases available as like a private software, but those tend to be a lot more expensive. And so these other platforms are often used more commonly. As you also, kind of when you're thinking about building your data set and your data variables, I would highly encourage you to look at as many clinical charts that you're going to be abstracting that data from as possible, because that's the only way you're going to know if it's actually feasible to collect each of those variables that you want to collect. And as you do that, you'll realize that you really do need a clinical background to be a data collector for a registry. And the reason is because there's often some element of clinical interpretation, realizing that maybe someone documented in a different piece of the chart, but you really have to be able to understand the local context as well as the way that things are locally documented. And so in Zambia, they're currently using paramedics as their data collectors, just given that there isn't a kind of alternative place for those paramedics to work. Most registries use nurses as their data collectors, but almost everyone has some type of clinical background. When you're thinking about your data collection, you also want to think about how you're going to integrate kind of quality assurance into that process from the beginning. And this kind of gets us into the next topic, which is your data analytics, which really go hand in hand with your quality assurance, because you have to know what you're going to use that data for, not in the sense of a research question where you're thinking, okay, I need to collect 6 months of data that I'm going to analyze and then I'm going to do kind of the statistics on it. But you actually want to be able to use some of that data in real time. And this is an example, an example of, excuse me, some of the analytics that are available with the ERTEC platform. And so these analytics are actually available live. In REDCap, you can also integrate with a software platform called Tableau, which will also give you data visualization and data analytics. And this is really important, one, from your quality assurance perspective, because you can track how much data is missing. You can see if you're getting the expected number of patients per site. You can also just get a general sense of what is your registry telling you. Are you able to sort of categorize by injury type or by gender? If you are managing kind of a countrywide data registry, you would have access to all your different sites, and you could compare across the sites. And importantly for ERTEC, it is a secure platform, and so if you are a data collector, you can only see data related to the site that you're collecting data from. But if you kind of have higher access privileges, similarly in REDCap, then you can see a higher level of that data. So one of the things that is also important for that kind of quality assurance is determining what your quality indicators are going to be. And this circles back to thinking about what data variables that you collected. So for example, if you are doing, you want to keep track of patients who have a significant head injury, then maybe your data elements are going to be what the GCS of was that patient. And so all the patients that had a GCS less than 8, you're going to also track the variable of was there an airway intervention, yes or no. And that's kind of your quality indicator. You can kind of have infinite numbers of quality indicators, and it really depends on kind of the amount of data that you have available to you and the strength of the clinical documentation that you're abstracting your registry data from. So my one take-home point for you guys is really to think very, very carefully about what data variables you're going to abstract for your registry. And if you start that step off carefully, you can build a really great registry from there, but it's really hard to go backwards and try and fix your variables. So with that, I will move this to our next.
So we'll transition now from a sort of a more global registry, and we'll zoom in on South Africa. I'd like to case study the EPIC registry as an example of a multi-center registry, with a disclaimer that this registry is early in its, it's early in its growth. It's still in its infancy. So EPIC is a research-born and driven registry that primarily seeks to assess to understand the epidemiology and outcomes of patients who've been gravely injured but experience prolonged durations from their point of injury until definitive care. I think for a lot of you who work in LMICs, you know that this is the paradigm, unfortunately. EPIC is funded by the US Department of Defense, and you may be wondering, why would the US Department of Defense fund this sort of work overseas? Well, there are parallels between gaps in military medicine and the paradigm of care I'll speak for South Africa, specifically in the Western Cape. So gaps in resuscitation and delays, the use of TXA and blood products. So South Africa has a balance, because it's a middle-income country, of some low-income features and some high-income features. And I think that makes research over there quite generalizable in several senses. Additionally, South Africa has an extraordinarily large burden of disease from interpersonal violence and traumatic deaths. And so for many reasons, it's a really rich and ripe place to conduct research. And last and importantly, there are mature systems of care, including pre-hospital care, which is not typical in much of Africa, as an example. So again, some of those lessons can be translated to other systems as they look to seek and develop EMS. So that's what the EPIC study is. So it's a network of 12 sites. We have 4 hospitals, including a trauma center. There are 2 equivalents to freestanding emergency departments. We have 4 large EMS bases that cover these jurisdictions. And then we also have 2 forensic and pathology labs that uniquely perform 100% of autopsies on trauma patients. And so what EPIC allows us to do is capture data from the point of injury, if a patient has an EMS transfer, all the way through emergency department resuscitation, inpatient care, operative room interventions, ICU interventions. And if the patient should die at any point in their trajectory of care, we'll capture their postmortem details. So it's quite a robust registry, but the devils are in the details, of course. And while I won't get into all those details, one important feature is we use probabilistic linkaging to help link records as a patient traverses from one facility to another. So at the very end, I'm happy to answer any questions about that. So one of the first key points I'd like to make about EPIC and about establishing a registry, especially a registry that may traverse multiple institutions, is the importance of your stakeholders. And so the list of sort of icons or logos at the bottom is just to help reflect the fact that we have quite a number of stakeholders who are vested in the success of this work. So from left to right, the Western Cape Government Department of Health, of course, these are their patients. We're actually operating in public facilities. So these data do belong to them, and Catherine will talk more about that later in the presentation about. Next is the government EMS system. We use again, we're working in a public infrastructure, and so we have the luxury of having a state-run EMS service, so they're a core collaborator. Our primary academic partner is Stellenbosch University. For obvious reasons, it's critical to have the academic collaboration between our university and Stellenbosch University, with the University of Cape Town sort of being a secondary academic partner. And then, so our university serves the role of the data coordinating center. It's sort of where the data are received. We help orchestrate the conduct of the work. I personally have to manage relationships and so on, and that's what I'd like to talk about in the next slide. So the registry, we started collecting pilot data in late 2020. And we actually started conceiving of and designing the registry conceptually in 2017. And I labor this point because it took us about 3 to 4 years to really go around and, I'll use the term cautiously, but court our stakeholders, to really get to understand them, who they were, what their needs and expectations would be should we embark on this work. And I I would encourage all of you who are sort of embarking on this work to really think critically about who the diverse groups of stakeholders are who could potentially have a role either in the design and the execution of the work or consuming the products from the work. So knowing who they are, the spheres of stakeholders are critical. Understanding their expectations is critical. Having an a priori plan on how you're going to engage with your stakeholders, with what frequency, in what format, how often, and how are you going to manage them? And I use that term loosely, but manage their expectations, recalibrate their expectations if they expect too much of you or ask something that's unrealistic. So in these three bubbles over here, I've tried to sort of give a loose representation of who some of our key stakeholders are in South Africa, internationally, so beyond, sort of in between South Africa and the US. And our sponsors are actually a key stakeholder in this work for obvious reasons. And the sponsors are twofold. They're both the US Department of Defense, so our financial sponsors, but actually the Western Cape Department of Health, even though they don't directly pay monetarily to the work being done, actually critical. In a letter they wrote for me, they identified themselves as a sponsor of the work because they're allowing us to do the work in their facilities. And I thought that was really interesting. So I have to approach them as such. So what I'll do now is maybe just spend another minute just talking about the various tiers, if you will, of stakeholders in South Africa. So the clinicians, I think, are, to me, quite obvious. But their expectation is to have data about their clinical practice around trauma care. And they want those data yesterday. And so therein, we have to sort of recalibrate the expectations, work with the heads of the clinical units to try and understand, well, what exactly do you want within the constraints of the data we collect? And create dashboards and metrics we can provide for them. Q3 months, when I'm there, we'll organize, we'll invite the clinicians to come see a presentation on some of what we've done so far and some of the key findings, the delays in care, resource utilization, missed opportunities for care. And these are exhausting, but they're pre-planned, they're deliberate, and they allow the clinicians to see the value of the work we do, which indirectly sustains us. As a matter of fact, sometimes we sneak in variables that are often missing and remind them gently to improve their documentation of those variables. Now, selfishly, that improves the quality of the data, but indirectly or directly, that benefits them. So one example. At the facility level, the managers of the facilities want something different. They want data to show processes and gaps around resources. They want data to help them fight and advocate for more resources at their facilities, be it a radiographer after hours to operate the CT scanner, or even having an X-ray machine or an extra ultrasound. So whatever it is. So I realized very quickly that their need was quite different, and the way we had to build our research database to be able to meet some of those needs had to be tweaked a little bit. And without the support of the managers of the facilities, rest assured, this work does not happen. So it's imperative that they see value, and they see value quickly. So we're not going to give them these data 3 years or 4 years from now. They have to be sort of coming in on a semi-frequent basis. Researchers, of course, also have some ideas, South African researchers, that is, some questions they want answered along the way. And I think it's critical that we collaborate and we help them answer the questions they want to answer because we're collecting a mountain of data. To give you an idea, in 9 months, we have 5 million pieces of data that correspond to about 5,000 cases. So this is a massive repository of information that must be shared. The Department of Health, of course, wants things on the system level, and then a policymaker is ultimately looking for pieces of data that will improve them. So to give you an idea, we recently concluded a preventable mortality study where we brought together 21 clinicians involved in the spectrum of trauma care, all the way from EMS to the forensic pathologist, to review 150 trauma cases. And these were all death cases, pre-hospital and in-hospital. Now, the research study was a sort of a convenient arbitrator, if you will, a facilitator for the discussion. We had the luxury of having all the cases. We identified them. We could bring them to the discussion. But the outputs were not primarily benefiting the trauma registry or the research study. They were directly intended to improve local processes and trauma care. And so we're going back in 3 months to hold a summit to present the findings back to the stakeholders. And again, this is a sort of an intentional byproduct of the trauma research, not perhaps the primary goal, at least of our trauma registry. But long way of saying, understanding what they want and being able to give back responsibly only sort of, I think, strengthens the position of the study and frankly gives you more contextual understanding to be able to go forth and do even better work. So it's a win-win for everybody. To give you a flavor of the growth of our trajectory of our registry. So again, we started pre-2020, understanding our stakeholders, understanding clinical documentation, spent weeks to months in these facilities to really get to understand where the data lay and the constraints they had. So for example, one facility says, we have no room. Forget about having somebody who needs a space. It ain't happening. So figure something else out. But yes, you're happy to come and collect data. So we spent about 2 years performing pilot work, developing instruments, talking to experts to gain consensus about certain variables where consensus didn't exist. We had to, of course, gain facility approvals, all the ethical approvals, design our instruments, hire and train our team, and do robust quality assurance before we could start pilot testing. And then we spent about, I think it was about 6 months only doing pilot testing. Halfway through, scrapped the whole database, reformulated it, started collecting data again. So there were 2 iterations of our database before we landed on our final version of our data set. So we're now in the sort of main phase, and you'll see it has a sample size written next to it. That's only because the research was born, so the registry was born out of research, specific research questions that had a sample size associated with it. But know that for every 1 research subject we collect, there's 2 additional patients who are not specifically intended for the research study, but as part of, to sort of populate the registry so we can give back information to our South African colleagues about their trauma care. We have an a priori plan on how we're going to institutionalize the registry. So I guess as a global health scientist, it would be a shame to invest this much effort into implementing such a robust system of collecting data only to have it end abruptly at the end of the funding period. So we actually have a plan, which is sort of a work in progress, on how we can show value and integrate these registries so that they're locally owned and driven within these facilities. So right now I can't tell you if that's going to work or not. Check back in maybe 3 years and we'll have a better sense. So a few examples on some of the deliberate, let's call them sub-studies or areas of sub-investigation along the way. So we identified a large burden of disease due to Crush syndrome and huge mortality from it. So we're developing a Crush syndrome scoring tool. We completed the mortality, the Preventable mortality study that I just told you about. And it was really fascinating to hear that this was the first time in their system that they had a system-wide preventable mortality study. So one of the participants came up to me and said, if nothing else comes of this, just getting us all in the same room to speak about cases that have touched all of us was so eye-opening and has brought us closer together as a community. So I found that really interesting. We're going to do some studies focused around cyclocapron, so TXA, a pragmatic EMS trial. We have a blood product resuscitation study coming up mid to late next year. But know that we had a very deliberate, pre-planned sort of strategy on capacity building. So the folks we hire and the folks we work with, we have, that's actually built into sort of our ethics protocol, how we're going to develop capacity in them to teach them about registries so maybe they can go on and spur the development of registries in other sites beyond just the EPIC network. Same for our paramedics and our nurses. Our collaborator, many of whom are clinicians, frontline clinicians, some of whom haven't published before. So we get them involved in the publications. We show them how that works. We get them to present, if we can. And so those are all parts of our a priori capacity building plan. And so I'd urge all of you to think about those deliberate outputs. And I think I'm preaching to the choir here. A lot of you sort of being in global health understand this and do this naturally. So ultimately, and of course, we drive quality improvement activities, which I talked about at the beginning. So again, all of this with the end goal of strengthening the system and improving care. I'll touch on this very briefly, but I'd like to speak about data management or data end management. And I'll just emphasize the point Julia made earlier about the FAIR principles. So about 2016, a group of diverse stakeholders, including data scientists, funders, clinical researchers, and so forth, got together and I think born out of frustration of there being silos of data, came out with the FAIR principles, essentially to help catalyze the sharing and the use of data, of various databases. So in essence, the F is findable, so you should be able to somehow find the database or the data set that you're interested in using. So it must be, I don't know, published somewhere or listed somewhere that, or placed in a repository where others can go and search and see, okay, this data set exists, which could potentially satisfy my needs. So once you find the data set, is it accessible to you with the right permissions and levels of access? Can you actually get the data you want? So this means that there has to be metadata available, data about data. A data dictionary that explains the variables you have and the constraints of the variables. So somebody else who's not familiar with the data set can understand it before they can potentially use it. Interoperable, meaning it should be, if possible, be able to sort of talk to another registry, maybe having a common data set, common variables, like Julia was explaining before. And then reusable. So beyond the EPIC study, for example, let's say if EPIC ends in September 2024, can this data set be repurposed in some fashion to answer other questions? Could people link data on the back end to answer additional questions? Can it be merged with other data sets? So these are really important principles to keep in mind. So some key things that I think we're still struggling with and trying to develop as the study goes on are listed here. A priori, we had some ideas about how the database and the data would be used. Primarily for research, but secondarily for driving process improvement and identifying gaps in education and strengthening critical interventions and resuscitation. So I would encourage you all to think specifically about what the diverse uses for your data could be beyond just, for example, the research application. How are your data interpreted? I guarantee you that if I'm the only one doing the interpretation, we will miss the mark. I don't practice clinically there every day. There are so many nuances to clinical care that are contextually relevant, that having your collaborators, local collaborators by your side to participate in the interpretation of the data, absolutely critical. Next, ethics and ownership. Who owns the data? These are, in the case of the EPIC study, these are South African patients in the South African Ministry of Health system. Make no mistake, the data are owned by South Africans. I am a temporary, and the University of Colorado are temporary custodians of the research data, de-identified. So what happens if I have a collaborator in the US who wants to collaborate with me and answer a specific question using part of our registry? I have to go back to the South Africans and sit with them and talk to them. And so we have all this spelled out in a data share and use agreement. And it's a long one, and it's very detailed. And the lawyers have to get involved and co-sign to make sure we're doing the right thing for the, to protect the data, but also to allow it to be used responsibly. And then last, data transfer. So I think I touched on that briefly. So again, in many countries, there are laws governing what sort of data can be exported beyond the borders. So that has to be carefully considered. And of course, when it comes to publication, issues around who first authorship. I think there have been several publications that have actually looked at list of authorship and show that the high-income country authors typically first, second, third, and last. And maybe there's one low-income country author involved. So what are you going to do to try and sort of offset that? How can your local collaborators get to be first authors on some of these papers you publish? What about if they want to use the data for separate needs beyond maybe some of the primary research questions? Do you get involved? We certainly don't have all the answers, but I think there's certainly a lot to be considered. And these are quite nuanced, and these issues will come up. And they've come up for us. And so thinking about them in advance, I think, sort of pays off. So with that, I'll stop here. Perhaps more food for thought than answers. And I'll turn it over to Catherine.
Hi, thank you. So we have talked a lot about the details and the context, the specifics of why registries and how many people need to be involved. There is an elephant in the room. Who is going to pay for this? And honestly, every person and every situation is different. So part of what I'm going to talk about a little bit has been my experience in Tanzania, why we thought about a registry as sort of starting the process of trying to understand what is needed in that location, and why specifically we started with where we were and how we grew. So starting in 2012, I started working at KCMC Hospital in northern Tanzania. And at the time, they had no emergency physicians. They had one urologist who was grandfathered, as they say, and he was the only physician in the department. And there was a myriad of issues in terms of clinical care that needed to be addressed. Mostly, it was major deaths were due to traumatic brain injury in the region. So the first request of our collaborators were, can you understand why people are dying of traumatic brain injury? Needless to say, having an emergency physician might have been beneficial, but that couldn't solve immediately. So we started a registry that focused exactly on their question of traumatic brain injury. Over the next 5 years, we identified from that registry, while still waiting for emergency medicine physicians to be trained and come to the location, we identified some sub-areas of concern amongst the patients that were coming to the hospital. We found that 1 out of every 3 patients was intoxicated or had an at-use alcohol disorder. Very high-risk alcohol use behavior. The average time to coming to the emergency department was 8 hours, and for many of them to have a positive alcohol level 8 hours out was very concerning. We identified that traumatic brain injury was the leading cause of death. It was a significant contributor. There was no intubation happening in the emergency department due to restrictions in capacity at the site and training amongst the professionals. We found out that even once the patients were admitted, they made it through the emergency department, they got into surgery, there was no further assessment of what other needs need to be done. You have a fracture, let's talk about rehabilitation, never happens. Linkages to other processes within the health system wasn't happening, etc. So this got us to start thinking about, okay, so how do we now make this happen so that it works? So from our initial registry, which focused specifically on traumatic brain injury patients only, we pull out a story about alcohol. Understanding that alcohol was so incredibly common, we needed to think about that. We started to see that it was all due to road traffic crashes. Our motorcyclist numbers had exploded in 2005 to 2010 in the Moshi region. There were no and are no helmets, and there's not a lot of regulation in that area. So that brought us in the direction of bringing other safety and prevention initiatives to the region. We found that rehab just wasn't being utilized. It was actually there. We have personnel that are there, but there was no linkages in care between the patients who need it and the resources that we have. By 2017 or so, we started to change our direction and understand that traumatic brain injury isn't the only situation that's happening. We need to expand our view from the traumatic brain injury to a more broad view of trauma, and so adapted our registry with about an 8 to 10 month pause in the registry to think more broader to all of trauma. This was an NIH-funded R21, which funded a baseline registry, and then to understand what are the needs of the patients. Psychosocial needs, medical needs, HIV rates, understanding what kind of medicines they're taking, understand what kind of referrals or surgeries they need during their hospital stay. A very holistic view of the patients that are presenting, because we already knew they were mostly young men, and many of them had alcohol use disorder, but what other things are we missing? So this holistic view gave us a lot of information on how we need to move forward in care and treatment. And in 2018, we had our first emergency medicine physician come to the location. At this point, not only are we incredibly excited because we now have data to help him say, look, we're going to be able to do some care, we need to intubate, but he's able to intubate. And we're now able to start thinking about more of the emergency medicine acute stabilization processes and have an evidence behind it that shows improved outcomes, at least in the beginning of the hospital stay. As the registry continues, we start to look at the processes of access to care. We knew that the time to hospital was incredibly long, but how do patients get to the hospital? How many patients walked down the street to the hospital? No, complete seriousness. There's no pre-hospital system. How did they get there? What was the challenges that they encountered? And how, as we start to think about a pre-hospital system in this urban-ish setting, what does that look like, and how is it going to be taken? And then as we started to continue, we started to say, look, we still don't have a fully functioning 24 hours a day CT scanner. We have a problem. How am I going to go back to our TBI patients, which was the largest proportion of our patients, who are having serious injury and mortality, how am I going to be able to understand who is sick enough to get my very finite resource? Using this data, the 5 years of data from 2012 to 2017, we started thinking about predictive modeling. Can we understand more specifically within our health system, which has very different parameters and very different outcomes than other health systems, which patients are going to do well, which patients are going to do poorly without any CT scanning at all? There's not very many models that look at that because everyone just does CT scan first and then never thinks about anything else. But we don't have that access all the time. So we started a research line from those two registries, from the initial registry, that really brought us in the direction of not relying solely on that CT scan and thinking about predictive modeling. Now, where can we use that registry? KCMC is not the only hospital in the region, it is the referral hospital. So who should be transferred to that hospital? So using these kind of tools have been able to get us to think about what is coming out of this registry, even though it might not have been the question of the original registry, which is what's happening. At that point, as we started to layer the data that we have, we thought about something called the grid. It's a repository, a global repository of injury data. Why is this important? If we take a look at data from each individual country, there's going to be many things that are the same. We're probably going to find that most patients are young, healthy men. There's going to be a high proportion of alcohol use. There's going to be a lot of injuries that are traumatic brain injuries and fractures. And the worse the injury, the worse the outcome. But the differences in the health systems are going to have dramatic differences in the outcomes. And so understanding, especially as a health system progresses in its growth and development, the changing of their improved statistics and their improved outcomes is going to change with it. So rather than having just the same exact process, and as the health system changes, you still have the same clinical decision rule, we need clinical decision rules or concepts that change with our health systems as they grow and develop. So by overlaying data from different locations, different health system levels, or similar health systems, let's say a country that looks very much like Tanzania, would be able to get, one, more patients to improve our prediction models, and then two, a good understanding of what might happen as our health system improves and we have more and more emergency physicians that are able to stabilize patients. As we continue through the process of this registry and understanding all of the things that can come out of a registry or two registries or systems of registries, we then started to give back after we've identified some of these priorities and to grow and bring research as a priority to the area. So even more recently, the intervention that's dealing with alcohol, we've been able to create a clinical trial that now supports our current registry, which is called PRACT, Trauma Registry. It is our ability to identify who needs to be enrolled in a pragmatic trial dealing with an alcohol harm reduction. So while the goal of the registry is to be a list of all the patients that come to the hospital who have an injury and do the preliminary screening for a registry, we're also able to include the WHO minimum data sets. So we're able to be conform to the FAIR principles and share data to be able to support the next research question that is needed for the location. On top of that, we now have said, okay, we have a lot of data. We need help. We went to our team there at KCMC and said, we want more data scientists, implementation scientists, and we want more people who are focusing on this kind of data. Let's train some people. So with my collaborator in country, we've created the TREC program, which is a trauma education capacity building in Kilimanjaro. It's a D43 program out of Fogarty that is training 10 master's students and 2 PhDs. Many of them are using the data from our registries, any one of them, all of the data that we have in our research programs and portfolios to be able to answer specific questions and think about implementation. The goal is that we will continue to have NIH or other funded monies to keep the registries going. We'll be having local collaborators lead some of the questions and guide the direction of the next steps in a goal of moving things forward. So as we think about how long this takes, this is a really long time. We started in 2012. It's going to be 2025 by the time our D43 is completed and the program is completed. But during this process, even though quality improvement was the way that we started to think about things, we've been able to understand and learn about data and data architecture, how this works, how we need to put them together, how we make things fair and interoperable, especially in lower resource settings, behind somebody's firewall, whether it's our collaborators at KCMC or whether it's at Duke. We've been doing foundational research capacity building. Emergency medicine itself, we now have 4 trained physicians at site, and all of them have access and are using the registry for some kind of research project. But we need the research capacity to do the implementation alongside our clinicians. So having a research capacity building program has been influential in not only getting the attention of our local stakeholders, but also allowing us to move forward. We're building unique and innovative skills like data science and advanced analytics, allowing this to be a platform for pragmatic trials and other clinical trials that are needed in the area, in all of serving the primary goal, which is quality and timely emergency care. So registries are complex. You have to start with an incredibly specific reason of doing what you're doing. Why are you collecting this data? The ownership of data that we've talked about many times, especially when you come from a framework of grant-funded registries, is really challenging. Our patients are Tanzanian. The data is approved by our KCMC hospital, which is a part government, part nonprofit hospital. I have to get approval to access it myself from the national regulatory bodies in Tanzania. The challenge is NIH thinks that I am the PI, therefore I own the data. So when NIH asks for the data from their national sharing policies, they just expect I hand it to them. But they don't know what's happening on the Tanzanian side and know that that's not really the way that it goes. So understanding that ethical ownership is continuously problematic, I will say it that way. While I might have a data share agreement, I am not allowed to share the data with anyone else because it's been shared with me, yet I have to share the data with NIAAA because they're a funder. So it's always something to think about and understand as you're getting into these relationships. You need to think about timelines. As you can see from all of our timelines, they're not 6 months, they're not a year. We're talking on span of 5 to 10 years to be able to have an output that is massive, but it has to start somewhere. So thinking about timelines and thinking about stakeholders as you start these processes is incredibly important. Capacity and capacity building. Everything we do is going to build capacity, whether it's research capacity, clinical capacity, capacity to do quality improvement. All of it is incredibly important, and it can come from a registry in and of itself. So I think that's all that we have. We're happy to answer any questions. Anyone? Any questions? Shrav. I can hear you. Yeah.
So, I'm obviously very excited about all of this. I've been working on this for a while as well. One thing that is devastating to hear, though, and I'd like to listen to your thoughts as developing registries and implementing it, is it takes so long to build and to reach a place, and then what is next? What if it's happening on somebody who wants to start this now, thinking they don't want to get their products in 10 years? So how can you, from your experience, is there a way to streamline this process for new registries in other countries, or ways that we can maybe, I don't know, learn from these experiences?
Yeah. Do you want to answer? I have an answer. No, go for it. So I think that's a hard question because everything we said is this is going to take a long time. Part of the fact that why we wanted to do this is because we don't want you to go through the same challenges that we have gone through in creating this and trying to put all of the problems together and solving them. Part of our goal is to identify the best ways to start so you don't have the decade-long ramp that many of us have had getting to where we are. So there are data collection sheets from the WHO that are standardized. Start there. There are data collection mechanisms, like we talked about, ERTEC and REDCap, that will help you collect the data. Start there. We are here to answer questions because we want you to do it and would be able to help understand where the challenges and the roadblocks are to start there so you don't have a 10-year ramp. One of the other things to do, and I know you asked the question specifically because this is your area of interest, is as we overlay some of these data, we can do something called transfer learning. So we learn from similar locations about things that are correct. So for instance, the predictive modeling that we talked about in traumatic brain injury and KCMC, we can predict outcomes for patients both at KCMC and also reliably in Rwanda because they are similar, not the same, but similar health systems. So as you are starting your registry, you might be able to, before you even have a ton of data, be able to have some linkages with other data sets and better inform your data to have a better output faster because of the ability to make your data interoperable and therefore shareable. And you'll have a larger network to sort of demonstrate the benefit of these data to your team and get that buy-in. Part of the reason it takes us so long is we've been starting from fairly limited areas and we have to make that sell. If you can make that sell quicker, your stakeholders are going to get what they need and therefore be more bought in, and it moves the process faster. Do you have other things?
Yeah, just to add to that, I think if you can anticipate some short-term wins along the way, either for the research program, for quality improvement, for your stakeholders, I would urge you to do that as a way of fueling everybody's and sustaining everybody's enthusiasm. So for us, our research questions won't be answered until late in 2024. But along the way, every quarter, every 6 months, we actually have a mountain of data that has a lot of rich findings that can drive local process improvement activities, can inform and catalyze new studies. And I think these are the things that keep us all going, along the journey. So I encourage you to think about what those short-term sort of gains and wins are along the way. Yeah. Any last questions? Yes.
Thank you for the presentation. Very interesting. So my question is on linking and reusability. It's all a little bit about it, but I want to be sure whether it's what I'm understanding. With the data you have, who give the link to, we talked a little bit about the community, the health systems, but we also know that trauma goes beyond the domain of the hospital. In fact, it goes beyond the domains of what things to do. And you talk about alcohol. So are there elements in the data that could allow researchers or any other person who wants to do quality improvement to link this data to, let's say, community surveys or environmental data, such that they don't have to create the process?
Part of the FAIR principles talks about reusability. The most important thing about reusability is understanding the data and how it was collected. Our data specifically has alcohol use, and it has alcohol use disorder tests for our patients that are presenting for a trauma at that date and time and issue, et cetera, in their healthcare process. I don't have where they live because I don't have a GPS link. So I don't specifically link a patient to anything in the community that's currently there, but I can have a regionalization of the data and understand where they're coming from on sort of the regional level if I want to compare to a different country. Certain data sets might have more information. So for instance, we work in Brazil where every data point is matched by your social security number. There's a unique identifier. So I can do just that and identify with reason where you live, what's going on around you, and all of your health visits and what that looks like. So you can link data that is your health visit and where you live in some community aspect. The data has to be collected with a unique identifier that matches in some way. Part of what you were talking about is the probabilistic matching, and you can talk about how that's done in your process a little bit more. But it depends on the data set. You set up the data set to know whether or not it will link with certain processes. And that's something you have to know ahead of time.
Yeah, just very briefly, so if you're collecting data on patients who traverse the trauma system, obviously you're going to need to match records at different facilities, EMS facility 1, facility 2 if they die from forensic pathology. And we know that names change as a patient moves from facility to facility, dates of birth, different identifiers come and go. And so I would urge you to just look up probabilistic linking. Essentially, all that means is you start from some identifiers you might have, and frankly, through a series of logic, and you can actually write out the logic, logical statements, try and figure out whether or not, with some degree of certainty, whether or not you actually have a match, whether chart A at facility 1 matches chart B at facility 2. And so those sometimes can be combinations of first and last names, dates of births, ages, dates and times the patient arrived, the mechanism of injury, the location of injuries on the patient, and so forth. So there's actually a hierarchy of logic you can use and you can write out to help you with, identify the level of certainty which you're matching two records together. So I hope that helps. I think we're out of time. Would like to thank all of you for spending your hour with us. Really appreciate it. And we're happy to take any questions maybe outside the room. So thank you all for coming.